Thank you for coming to our internal medicine grand rounds. It's my pleasure to introduce Dr. Peter Green. He holds the distinguished position of the Phyllis and Yvonne Seidenberg Professor of Medicine, as well as the position of the Director of the Celiac Disease Center at Columbia University in New York. Dr. Green obtained his medical degree at the University of Sydney in Australia, where he completed his residency as well as his training in GI. He became a research fellow at Harvard Medical School, Beth Israel Medical Center in Boston, and subsequently moved to Columbia University in New York, where he remained. Dr. Green main pursuit is clinical care of patients with celiac disease and research into the clinical aspects, epidemiology, basic research in celiac disease and other gluten-related disorders. Dr. Green has authored over 300 publications on celiac disease, lectured widely to medical students, medical professionals, and the public about gluten-related disorders. He's authored many of the most recent medical reviews on celiac disease, published in the New England Journal of Medicine, The Lancet, BMJ, Analysis of Internal Medicine, as well as JAMA. Please join me and give a warm welcome to Dr. Peter Green as he gives an excellent presentation on celiac disease and gluten sensitivity. Is there a difference?
Thanks very much for the introduction and for inviting me here. There's a law, I think it's called Breckinridge's Law, that if in a newspaper headline you see this question, the answer is usually no. But I think the answer for this question is actually yes. So that's the end of the lecture, actually. A few conflicts. So what are the gluten-related disorders? There's celiac disease, which is this unique autoimmune condition, and it's unique amongst the autoimmune conditions because we know the environmental antigen, whereas we don't know that for rheumatoid arthritis, multiple sclerosis, etc. Wheat allergy, because people who have a wheat allergy need to go on a gluten-free diet, and then we have PWAGs, people who avoid wheat and gluten. Some of these people might have non-celiac gluten sensitivity. Now, typically, non-celiac gluten sensitivity is a self-diagnosis, and we will address this. As you know, gluten is the main storage protein of the cereal grains, wheat, rye, and barley. And you can see in this genetic tree of the grasses that these grains are separate from, genetically separate. They branch off here from these other cereal grains that are not toxic to individuals who have celiac disease. Now, actually, anyone here read Guns, Germs, and Steel? Yeah. And Sapiens? Yeah. So Guns, Germs, and Steel, Jared Diamond, he suggested that man domesticated wheat, right, in the Fertile Crescent, and that changed the way we live. We could live in villages, towns, store food for the rest of the year, and you could make money from doing that. Hari, in Sapiens, says that wheat domesticated man, in that prevented him from going out in the fields, chasing deer, climbing trees, etc., and forced man to live in villages, towns, etc. But wheat has been important in civilization, and it's actually a very healthy grain. It's got all these vitamins in it, but what's very ironic, in the industrial milling process, it loses all the vitamins. But it's a healthy grain now because it's been fortified. It started in the United States in the 50s to fortify wheat flour with folic acid to prevent birth defects, whereas none of the other grain flours, such as rice flour, is fortified. And so someone on a gluten-free diet typically will become folate deficient because of this ironic fact that healthy wheat made unhealthy and then it's made healthy and fortified. Now, how common is celiac disease and what's happened? So this is a study by Joe Murray that he took serum from this Warren Air Force Base cohort, which was taken in the 50s, basically young white men going into the Korean War. And this serum has been used in streptococcal antibody studies, 2 Hep C studies, and this celiac study, so it's been very well preserved. And you can see here that about 0.2% of these 20-year-old white men in the 50s had a positive tissue transglutaminase and endomysial antibody. So they had celiac disease, because these are good markers of having villus atrophy. And then if you take the current cohorts, which is 20-year-old white men in Minnesota or 70-year-old white men in Minnesota, born the same time as these guys, it's about 1%. So celiac disease has increased 4 to 5-fold over this 50 years. We should discuss why that could be. Now, how common is it currently? So this is another study which has used the NHANES data set, which you all know that NHANES is the National Health and Nutrition Examination Study survey, in which 5,000 average Americans are involved every year, and they have full physical exam, history, and body fluids, etc., are stored, and you can do studies with these. And for a period of time, they asked individuals, do you have doctor-diagnosed celiac disease, or are you on a gluten-free diet? And then the TTG and EMA were measured. And overall, 0.7% of the population, or about 1%, had either doctor-diagnosed celiac disease or had a positive TTG and EMA. What was very ironic that about this time, which was probably nearly approaching 10 years ago, an equal number of people were on a gluten-free diet. And amongst these with celiac disease, only 17% were aware that they had it. So you had this paradox. You had all these people with celiac disease, of which only a few were on a gluten-free diet, and you had all these people on a gluten-free diet, of which only a few that we actually knew really should be on the diet. So what's happened subsequently with the NHANES? Well, you can see that actually over this period of time, this 10 years, that the amount of celiac disease has remained stable, but there's been a fairly large increase in the rate of diagnosis. So now we say about half those with celiac disease are diagnosed, and we think that's mainly due to doctor education. But over this time period, there's been a big increase in the number of people on a gluten-free diet. So this study shows that about 2% of the population are on a gluten-free diet. Now, why do we have celiac disease? And the question comes up, why don't more of us have it, actually? Well, you've got to have these genetic markers, these HLA-DQ2, DQ8, of which 40% of us have. And you've got to be eating gluten, of which 98% of us are. But only 1% get celiac disease. So that indicates that these environmental factors are important. And what are some of them? So a lot of studies have been done in childhood celiac disease. And celiac disease is interesting because it can occur at any age. And you can get diagnosed at any age. From age 1, if they're eating gluten, to the oldest I've seen, a new diagnosis in an 87-year-old individual. So breastfeeding is thought to not be protective in a couple of big studies. And timing of gluten introduction. There are 2 very big studies involving about 2,000 children who are at risk being family members in Europe. And 2 studies. One study gave a little bit of gluten between 4 to 7 months, as the allergy people are suggesting, because it was thought that this might protect children. And another study delayed gluten to 12 months. And in both of those, it didn't make a difference. The factor was the strength of the HLA-DQ2. Homozygote DQ2 children, 30% got celiac disease within 5 years. So it was a genetic influence. But there are other environmental factors. Being born by cesarean section increases the risk. Having GI infections, rotavirus in children, troops that went to Iraq and Afghanistan, if they got Campylobacter gastroenteritis, it increased their risk of a subsequent diagnosis of celiac disease. And more recently, a reovirus has been shown to be important, and reovirus has been thought to be totally innocuous, common infection in children. Season of birth, being born in the summer month in the northern hemisphere increases your risk of getting celiac disease. any antibiotic use for children or adults, iron supplementation in pregnancy, PPI use increased the risk of getting celiac disease. H. pylori is protective. So a lot of these suggest the microbiome is important, but as I mentioned, it's not clear why it happens at any particular age. So anyone here got any ideas about what ethnic group have increased risk of celiac disease? What's that? Okay. Any other ideas? Well, we did a study. We looked at 400,000 biopsies looking for villus atrophy, and working with some of these people, Robert Genter, who had a name algorithm that you can classify people's ethnic origin based upon their name. And the group that had the highest prevalence of celiac disease were Northern Indians, Punjabi, which was threefold that of the general population. And it was not increased in Ashkenazi Jews as opposed to IBD that we know about, and it was lower in Southern Indians, East Asian, and Hispanics. Now, how does it present? So these are children that have been seen at Columbia. Recurrent abdominal pain, growth issues, which is either failure to thrive in little kids or, you see the slides from there? If I get out of the way. And screening. And the people that get screened in childhood are similar to those in adulthood. It's family members, increasingly any child with any autoimmune condition. Typically type 1 diabetics always get screened. Sjogren's and PBC, they're the big group. And also Down syndrome. Amongst adults, this is taken quite a few years ago, a group seen at Columbia. Diarrhea was the trigger that led to diagnosis in the majority of people, but less than 50%. Incidental at endoscopy, people go into an endoscopy with reflux and come out with celiac disease. Screening is the same population. Metabolic bone disease. It's always kind of ironic and strange in this country how obstetricians have become the primary care doctor of females, and then they start to do bone densities and give people one of these magic drugs. If you go to a metabolic bone program, typically people will get screened for celiac disease. Anemia, and we'll discuss this. This is mainly iron deficiency anemia, but you can get B12 or folate deficient, and also an anemia of chronic disease in celiac disease. And then we have this other group. Of course, we have DH, or dermatitis herpetiformis. This is actually a dermatologist from Columbia who went through a program at Mount Sinai and Columbia, and for like 15 years had this terribly itchy rash. And it wasn't until she started to get alopecia and vitiligo and arthralgias that a rheumatologist tested her for celiac disease. And this is the classical very itchy blister of celiac disease, and this is all DH, and it responds to a gluten-free diet. And the diagnosis is made by a biopsy taken a millimeter away from a blister, showing direct immunofluorescence for IgA. And then the list of other causes: recurrent abdominal pain. The neurologists are a major source of referral for our celiac center, particularly these peripheral neuropathy docs. Psychiatric disorders, people with eating disorders. We're very interested in these dental enamel defects, like our adult enamel is formed by age 7, and marks on that can indicate the presence of celiac disease. Abnormal mild transaminitis. A chief resident was picked up at Columbia a couple of years ago with just mild transaminitis. If you take someone with an elevated AST, ALT, and take out the chronic hepatitis, celiac disease is much more common than hemochromatosis, alpha-1 trypsin deficiency, and Wilson's disease that typically get screened for. Low cholesterol. If you see someone with a cholesterol of 100, you've got to say, why is it 100? Why is it 110? it could be because of malabsorption, particularly low HDL. So the list of other causes is pretty great. The main issue with celiac disease is associated with increased mortality. Multiple studies show that people with celiac disease have about a twofold increased risk of dying compared to their age-matched population. And it's particularly malignancies, lymphomas, but also increased cardiovascular disease and pulmonary disease. And of course you have increased morbidity. There's association with other autoimmune conditions. The general population, 3% of people have an autoimmune disease. 30% of people with celiac disease have another autoimmune condition. And there's a good study from France where they can look at people because they keep getting health care even if they don't go on a gluten-free diet. And after diagnosis, there's a significantly increased risk of getting another autoimmune condition if people aren't strict with the diet compared to those that are strict. Fertility issues, anemia, fractures, etc. So celiac disease has increased morbidity and mortality. So it's actually a satisfying thing, at least for the doctor to diagnose. It's not satisfying for the patient because it's a major lifestyle change, going on a gluten-free diet. So how do you make the diagnosis? Well, there's got to be a clinical suspicion. So that means a patient has to go to the doctor. You know, if you looked at those earlier studies, it was about 1% of white men have celiac disease, at least in the Midwest where it was studied. And it's about 1% of women. But women get diagnosed 2 to 3-fold more frequently than men. And I think that's because women go to the doctor. Most men don't get a letter from the gynecologist saying that you've got to come along for another exam each year. So it's interesting because if you look at children, it's about 50% male-female. And if you look at the elderly, it's mainly men that present with celiac disease. And so amongst older adolescents and young adults, it's mainly females and not men. Whereas we know 20-year-old white men, it's about 1%. So you've got to go to the doctor, and the doctor has to think about it, right? And if the doctor thinks about it, you've got to order the tests. And the best test is the tissue transglutaminase IgA. Frequently there are panels, and if you look at the commercial labs, they have a regular panel, they have a super panel, they have a deluxe panel. And so it's quite confusing what to order. If people just got a TTG IgA, they pick up about 90% of people with celiac disease. Selective IgA deficiency occurs more commonly in celiac disease. It's a common genetic disorder in the general population. It's more common in celiac disease. So if you don't make IgA antibodies, you can't have a positive TTG. So typically a panel will have a total IgA to see if there's selective IgA deficiency, and then an IgG antibody is thrown in, and the best one is the gliadin peptide IgG. But just thinking of the disease, doing a TTG IgA will pick up the bulk of patients. And then people should be referred to for a biopsy, because currently abnormal duodenal biopsy is the gold standard. And we have people with potential celiac disease in which they have a positive TTG IgA and a normal biopsy. So we would say that's potential celiac disease, and they wouldn't go on a gluten-free diet. That's providing enough biopsies were taken from the right places. Because if you follow people with potential celiac disease, some remain positive, 30% lose the antibodies, and 30% go on to get villous atrophy. So a gastroenterologist really should be involved, and then people start a gluten-free diet. Now, what about this delay in diagnosis or underdiagnosis? So multiple studies show a long duration of symptoms, a mean of 11 years. That's a long time, to have symptoms. In Northern Ireland, where doctors are very much aware of celiac disease, up to 30 clinic visits about a symptom before getting diagnosed. In Germany, 8 years after seeing the doctor. So all of this is a doctor delay in diagnosis. And in Finland, where they really know about celiac disease, and it's thought that the bulk of people are actually diagnosed, for a group of people, actually 30% had more than a 10-year diagnostic delay. So the problem is men going to the doctor, and then the doctor thinking about the condition. And in this country, unfortunately, a lot of this has been taken over by functional medicine people, and a lot of people are getting put on a gluten-free diet without a good basis at all. So I think as physicians, we've got to take back this disease because it's common and it has many ramifications, both in diagnosis and treatment. So addressing a general medical audience, we could think of iron deficiency anemia, right? This is common, and it could be caused by celiac disease. And there are guidelines that in the GI literature and in Britain, in the UK, that anyone with iron deficiency should be tested for celiac disease. Doesn't matter what age. And so we did a meta-analysis, and about 3% of iron deficient anemic individuals had celiac disease. And it didn't matter about the age. Like Paul today said something about, menstruating female, like indicating that I probably wouldn't think about celiac disease, but that is not so. It doesn't matter what age. There was no effect of age, gender, year of publication, nor country of study altered this prevalence. So basically, 3 in 30 individuals who have iron deficiency anemia potentially have celiac disease. So we had done a questionnaire. I love doing questionnaires because it's like a nice, cool little publication, and you get a feeling of what is going on out there. So we got email addresses from the American Hematological Association, or whatever it's called. And so we asked about the consideration of celiac disease. And basically, we had responses from nearly 400 practicing clinicians, 40% of whom were teachers, right? University-affiliated hospitals. And only 8% considered that all patients with iron deficiency anemia should be screened for celiac disease. And interestingly, more recent graduates were more likely than more experienced clinicians to screen for celiac disease. So that's medical education catching up. So iron deficiency anemia is just an example of where some of the celiac patients are. And if one changes one's, because I was always taught that if you see a menstruating female, that's a cause of iron deficiency anemia, period. Excuse the pun. Now, what's very exciting about celiac disease, and it's quite ironic, that people with inflammatory bowel disease, in whom we have many, many fantastic drugs, are seeking a diet to cure them. And people with celiac disease are seeking a drug. So the pharmaceutical industry is like slowly picking it up. And this is a slow process, right? It's little pharma picking up targets and developing and proving it, and then bigger pharma taking over the drug. And there are 3 modes of therapy that have been proposed and are marching along into phase 2 and phase 3 studies, actually. One of them is a glutenase, because none of us really digest gluten, and it's these toxic amino acid chains that cause celiac disease when they interact with get deamidated by tissue transglutaminase. So this glutenase has been developed, and it's one of a few enzymes that have been proposed, that have been studied. And then there's a tight junction modulator, lorazepatide, And more recently, as a company that came to the States out of Australia, NextVac, Immusan T has developed a vaccine. It's not actually a vaccine, it's more immunotherapy in which these toxic peptide fragments are injected, and they actually appear to be protective, and this study is marching on. So I tell people that in a certain time there's going to be a therapy to help them. Initially, all these therapies will help with the diet, and then possibly they may replace the diet, especially now that so many different targets are being evaluated. And the companies that have got these IBD biological agents are very interested in celiac disease. And like one can predict that in the future that someone's going to get a diagnosis of celiac disease and they may get the vaccine, or they may get like an annual infusion with a biological agent, and it may allow them to eat a regular diet. That's a bit far off, but one can see that actually in the future. Now, what about this entity of gluten sensitivity? You know, if you watch late night TV, Jimmy Kimmel's got a very funny thing about gluten Putin, people being on a gluten-free diet, not even knowing what gluten is, all the late night comedians, and like you can look at the New York Times, and there are a few articles, 5 or 6 articles each year on this gluten sensitivity. And this was back Newsweek in 10 years ago, actually, a new diet villain, and gluten. And so what is the status now of non-celiac gluten or wheat sensitivity? It's evolving. We have this information that a significant percentage of the population are on a gluten-free diet. There are wild estimates of this, partly based on buying gluten-free food. Like, we don't know how many people who buy gluten-free food are actually on a gluten-free diet or just picking up gluten-free cornflakes or something like that. And, you know, it's all around the place. You have these books like Grain Brain. And, you know, I really don't know what gluten is. This is Jimmy Kimmel's line. Djokovic went on a gluten-free diet and attributes him winning all the Opens. We've got to see what's happening in the next few days, obviously, in Melbourne. But he attributes his success to his gluten-free diet. And in his book, he describes how he was diagnosed with gluten sensitivity. And actually, a friend, a doctor, would hold white bread above his abdomen and test his strength. And consistently, when it was white bread, he was weaker. Gluten-free singles is apparently a lot of fun. And I'll tell you a little bit more about this at the end of the talk. And then, you know, you could look like one of these ladies, one of the Spice Girls, all these people, like you could look like that if you went on a gluten-free diet. And we have these books, Grain Brain. You know, I don't know if people know about this guy. There was a very good article in the New Yorker about him. Wheat Belly. I saw a 78-year-old lady from New Jersey a year ago. Her son is like a leading gastroenterologist from the West Coast. Her cardiologist gave her this book, Wheat Belly, and said, you really should be on a gluten-free diet. And so she came over to find out across the Hudson, which is pretty hard for some people who live in New Jersey, and you know, wanted to know if really she should be on a gluten-free diet, and there was really no indication. You know, Arthur Agustin, who did very well with the South Beach diet, you know, he saw the light and went gluten-free himself. So why would people go on a gluten-free diet? Well, you know, they might have celiac disease. They could have like IBS or some of the symptoms that people who have celiac disease. Like, you can go to the internet, there are 300 symptoms of people with celiac disease. Brain fog, arthralgias. And so people like the idea of being able to remove something from their diet and feel better. You know, it's like an amazing thing. IBS, and preventative, like neurological symptoms for weight reduction. You know, when the Atkins diet was very trendy, that's basically a gluten-free diet. I saw patients who came in and said, look, I went on this diet and I lost all my GI symptoms. Could I have celiac disease? And at least 3 of them that I saw, they were right. So if you reduce your carbohydrates, you typically cut out gluten and you can lose weight, but you might also treat celiac disease. You know, wheat belly and grain brain suggest it's better for general health. Cardiovascular, there's some cardiologists at least are recommending a gluten-free diet. A colleague of mine, his wife got depressed and the psychiatrist said you should go on a gluten-free diet. You know, so it's out there, autoimmunity. Most people, as I mentioned, who claim gluten sensitivity, actually it's a self-diagnosis. And diets are trendy. If you don't think they're trendy, look at this information. So this is Julia Bellows, who works at Google and published this in Vox.com. Now, she looked at Google Trends of diet searches. And in 2006, this was what it was. Now, the red is the South Beach diet. The light green is low carb. This pinky color is organic food. This is veganism. And so in 2006, in these areas in the country, this is probably in Colorado, this is Austin, Texas. I know where that is. But this is where searches were mainly gluten-free. And now look what happened over the years. Purple is gluten-free. So this is the last time. You know, it's interesting. These are the searches. And then this paleo diet came in. And once again, it's in these areas. So diets are trendy. And so it's interesting, amongst all the diets that there are, gluten-free is a medically prescribed diet, right? So it has a lot more authenticity than these other diets because it's prescribed. It makes people live longer if they have celiac disease. And there's this unsubstantiated treatment of people with autism with a gluten-free and a casein-free diet. That's very common. Most parents with autistic children will try that diet. So it's got some medical legitimacy. See, up in, probably not much else to do up in Alaska either. Or that's Hawaii, right? Or Alaska, Hawaii, something like that. And now we worked with Julia Bellows and people in the Mailman School of Public Health at Columbia and looked at factors in these economic zones that she analyzed for these Google trends and looked at the socioeconomic factors like income, percent of non-Hispanic white people, and then medical things such as amount of diabetes in the region, obesity, exercise, and availability of healthy food. And you can see that these areas in which the searches for gluten-free diet was more socioeconomic, both income and percentage of white people, compared to these health-related factors. And then this is market research on purchase of gluten-free foods. The most common reason was no reason for buying gluten-free food. And only 8% was because of a gluten sensitivity. Then we got some other information. There's this NEMA device that people can put bits of food in and put a capsule in, and it's like an ELISA. You can get a smiley face or a frown. The smiley face, if the food is less than 20 parts per million gluten. So people will take this to a restaurant, they'll use it at home. And so they did a lot of market research. Like, we don't know what the role of this NEMA sensor is. We actually just did a study in which we got sensors and we got these capsules. Like, it's expensive. Each test is not cheap. And we gave them to patients in a study and did quality of life and depressive indexes and that. And at least for adults, it appeared to improve the quality of life, being able to test the food that they were eating. But they did a lot of market research. And so we got their data, and they had information on people from all around the world, about 600 celiac people and 2,500 gluten-sensitive individuals. And so we looked at their information, and it was interesting that there seems to be this regional difference in gluten and food avoidance. There's significantly more people. So this is like the amount of people who had celiac disease and gluten-sensitive individuals. And there was more prominent celiac disease in the northeast, but there was more gluten avoidance due to gluten sensitivity in the west of the country. Actually, there is information from N. Haynes showing that there is more celiac disease in the northeast. And from N. Haynes, you can see that amongst normal individuals without celiac disease, there's a transition of TTG levels, lowest in the south, highest in the north, even within the normal range. But this is the result of the NEMA study. And also they asked about other food avoidances or sensitivities. And you can see that people who are gluten sensitive had a significantly greater avoidance of shellfish, eggs, dairy, other, peanuts, tree nuts, and soy. And interestingly, there's a regional difference in that in the United States, in that there's more dairy and soy avoidance in the west and soy avoidance in the south of the country. Kind of interesting. And there's international data from the NEMA, and this is the percent of gluten sensitivity. There's a linear relationship with the gross domestic product, with the US at the top, Germany and the Netherlands, Canada, Australia, and Argentina down the bottom. So all of this data suggests that gluten sensitivity is a socioeconomic thing, right? Now, what about patients that have IBS? Now, irritable bowel syndrome is a dietary thing, right? People eat and they get pain. It's related to their gut. A lot of it is food related. And so gluten-free diet was kind of popular for IBS patients. And so we didn't know. All the celiac experts around the world were lamenting about 10 years ago about why are these people coming in saying, like, I'm gluten-free, I feel better, could I have celiac disease? Or typically we see gluten-sensitive individuals in two circumstances in the Celiac Center. One, they go on a gluten-free diet, they get better and come in and say, could I have celiac disease, right? So we got a management algorithm for that. And the other group come in and say, I have IBS type symptoms, I went on a gluten-free diet, I know I'm gluten sensitive, but I'm not better. So that's the two groups that we actually work with. So everyone was lamenting about, like, what is this all about? And Peter Gibson in Melbourne, Australia, did this study in which he took self-identified gluten-sensitive IBS patients in whom celiac disease had been excluded. And he randomized them. He did a double-blind, randomized, placebo-controlled trial of gluten and gluten-free. And you can see that the patients were right. This actually made the New York Times, it made the Guardian. Patients were right. Patients knew that gluten was causing these IBS-type symptoms. And it was significantly different for this unusual satisfaction with stool consistency, which is a unique criteria, fatigue, nausea, wind, which we would call gas, right? So these headlines were, the patients are right, like this gluten sensitivity actually exists. So Peter Gibson is the guy that started this low FODMAP diet, right? FODMAPs are these things that cause gas. Like FODMAPs is it refers to fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. It's like fructose, people with fructose intolerance. So what he did is he took another group of these self-identified gluten-sensitive individuals and put them on a low FODMAP diet and did the gluten challenge study, and there was no difference. So they suggest that it's the fructans, the FODMAPs, that are causing the symptoms in these gluten-sensitive studies, and just recently did another study in Norway with gluten-sensitive Norwegian patients, and they gave them fructans and they gave them gluten, and it was the fructans that was causing the symptoms. But at about the same time, people from the Mayo Clinic, led by Michael Camilleri, did this study in which they took IBS patients that had not self-identified as being gluten-sensitive and studied them like in baseline and then on a gluten-free diet. And in these diarrhea-predominant IBS patients, they noted a reduced stool frequency on a gluten-free diet. And it actually correlated the slopes going down were the people that had the HLA-DQ and DQ8. So this suggests that there is a group of individuals with IBS that are gluten sensitive. Now, what about cardiovascular risks? It's not really right out in left field to think that maybe a gluten-free diet might help people. There's increased ischemic heart disease in celiac disease. It's a major cause of death in celiac disease. And there's a higher glycemic index of bread compared to table sugar. There's a protective effect of gluten-free diet in mouse models against diabetes. And if you look at population-based studies, there's inflammatory markers such as increased alpha-2 microglobulin in patients that eat a lot of gluten. So we worked with the people in Boston and looked at people that were enrolled in the Nurses' Health Study and the Health Professionals Follow-Up Study. And it's over 100,000 people, and helped develop this gluten index of just in a regular diet, the people that have a low or a high gluten or in between. And because these individuals have a very good diet history, baseline diet in 1986 and updated every 4 years to 2010. And the exposure in this study was gluten consumption, and the outcome was coronary heart disease. And in fact, people in the highest gluten intake had less coronary events. So a gluten-free diet, the people on the lowest amount of gluten had a worse coronary outcome. And it's thought that the reason is that people who avoid gluten don't eat whole grains that are protective. And there was another study so in regard to coronary artery disease, gluten is certainly not harmful, but a low gluten diet, this is not a gluten-free diet, but it's a low gluten diet, if it's low in whole grains, may be harmful. So they did a similar study using the same population and showed that there was increased type 2 diabetes in those people on the lower gluten intake side of this large population. So we don't really think that a gluten-free diet is very healthy. It's low in fiber, iron, and B vitamins, because, as I mentioned at the start, none of the non-wheat grain flours are fortified. Gluten-free products that you buy, the things that make things tasty are salt, fat, sugar, and wheat flour. And if you take out one of those, they usually add more in. So a lot of those gluten-free bars and that have a lot of fat in them, etc., cause bad reflux in some individuals. And there's increased heavy metals. Another study done using the NHANES data set showed that individuals on a gluten-free diet for whatever cause had increased levels of lead, mercury, arsenic, and cadmium, and urinary tin. And that's thought that it's because of the large amount of rice, because rice absorbs those heavy metals from the soil much more than other grains. And then we talked about heart disease and type 2 diabetes. And then the other thing that really we saw in the NHANES data, like people that take one food type out of their diet tend to take others out. And there's this condition, orthorexia nervosa, in which people progressively take food out because they regard it as being toxic. And there's evidence that there's increased anorexia nervosa in people with celiac disease. So we're actually very worried about people with this gluten-free diet, and actually showed that people who are the most vigilant take out other things and have a worse quality of life. So like we encourage people with celiac disease to be on a gluten-free diet, but then we don't encourage them to be too crazy about it because that actually affects their quality of life. And taking one food out tends to lead to people experimenting and taking other food types out. And the microbiome is thought to be very sensitive to the foods that we eat. So, currently the microbiome is the answer to everything, so maybe it's important. Now, but it's not all that clear. So we did this study in which we got a set of serum from Italian investigators that are very interested in gluten and gluten sensitivity. And we looked at markers of systemic immune response to microbial components, and looked at people with celiac disease, controls, and non-celiac gluten or wheat-sensitive individuals. And with these markers, which are markers of intestinal permeability that are not increased in celiac disease, but they were increased in these individuals who were gluten sensitive, and they went down on a gluten-free diet. So that adds to the confusion. And then in this study, you could segregate individuals, the healthy ones in blue, the non-celiac wheat-sensitive individuals, and the celiac disease, using a combination of these different tests. So it's confusing because the studies done by Gibson, there's no serum to examine in them, and these studies, we don't know about their FODMAP intake. So it's an evolving situation. But as I mentioned, there might be something about these gluten-free singles, because they appear to have more orgasms and sex. And you can actually be quite happy, apparently, on a gluten-free diet. We actually did a study. What percentage of the population have used marijuana in the last month? Give me some ideas. 20%? 5%? We looked at the NHANES data, and 60% of the US population in NHANES. But interestingly, those with celiac disease, it was only 40%. So whether this will make a difference, I don't know. And then Dr. Oz is on it, which we're all very thrilled about. And Dr. Oz tells us that Dr. Susan Blum will be able to get rid of gluten sensitivity. So thank you very much. Thank you.
That was great, Dr. Green. Thank you very much. We'll take this time for a few questions from the audience. Yeah.
So, how often do you see primary care practitioners see that the patients can have like a low STS population, and rather than doing a serologic testing and a biopsy with the GI consult, consider just jumping straight to a gluten-free diet? For those individuals, would you ever consider like educating them on consider a FODMAP diet instead?
Yeah. So the question is, I think the question was, primary care or doctors seeing patients suggesting a gluten-free diet. Should they try a low FODMAP diet first? Well, first of all, they should test for celiac disease, because once you go on a gluten-free diet, you lose the ability to diagnose celiac disease. Certainly, these individuals who are gluten sensitive we try to diagnose celiac disease, and we'll try a low FODMAP diet. I think that there should be more awareness amongst primary care doctors that they should test for celiac disease prior to trying any dietary therapy. Because patients, like the other thing is all the diet studies that have used gluten-free diet, FODMAP diets, regular diets, whenever you change the diet, patients get better. You go placebo to gluten, they get better, or they get worse. You go from gluten to placebo, they get worse. So just changing the diet in a study really has an enormous placebo or nocebo response.
Dr. Green, is there a way to predict, you mentioned early on that there's likelihood of other autoimmune diseases, and we know type 1 diabetes, Hashimoto's thyroiditis associated with celiac disease. Is there any way to know the other direction? In other words, the number of patients that have Hashimoto's thyroid disease, how often should we screen for celiac disease?
Yep. So, we did a meta-analysis. Any autoimmune thyroid disease has increased celiac disease, and they should be screened. One doesn't know the frequency of screening. Typically, when people get diagnosed with type 1 diabetes, they get screened for celiac disease, and then they get repetitively screened, but I don't know what the yield after that first screening is. People with celiac disease have increased risk of type 1 diabetes. I've seen people that have been very stable on their celiac disease, and then they've got type 1 diabetes in their 30s and 40s. So these conditions run along, but the question about frequency of screening, I don't think has really been addressed.
You mentioned briefly the microbiome. Is there any data on the microbiome in celiac disease?
Yeah, there is. It's very interesting that children that are breastfed, if they've got HLA-DQ2 or DQ8, they've got a different microbiome to those that don't have HLA-DQ2 or DQ8. So the microbiome, to a certain extent, is genetically determined. And then there's the other factor. If you put someone on a gluten-free diet, you'll change their microbiome. So it's not real clear, but in people with celiac disease and gluten as well as other foods, it will alter the microbiome. So one doesn't really know what the horse and the cart is, actually. Yes?
Can beyond antibodies can they change over time? I mean, could somebody say have celiac disease?
Yeah. Well, I've seen two people that I saw when they were very young, and then they went off the diet, and they didn't have celiac disease subsequently. And I had seen their biopsy. But I think, and then once again in France, where they follow people, irrespective, they seem to go to the doctor even if they're not on a gluten-free diet, there is a suggestion that a child may lose celiac disease. But we tell people that that does not occur. I've certainly seen adults present with adenocarcinoma of the small intestine that had a childhood diagnosis of celiac disease, and they were told in the 50s in this country that they had grown out of it. And they had adenocarcinoma of the small intestine, which is a very rare cancer in the general population, but is markedly increased in people with celiac disease. So we try to not tell people that they can grow out of it. Now, if you're just diagnosing this, there are pediatric guidelines in Europe that suggest that you can diagnose celiac disease without an intestinal biopsy. And in Finland, they're suggesting they do that with adults. But there are very strict criteria. And now if you see an adult who said, I had celiac disease diagnosed in childhood, you've got to find out whether that was a really valid diagnosis. Because people get put on a gluten-free diet for various reasons, because other family members might have celiac disease. But it's kind of dangerous. And another interesting thing that most children with celiac disease get no transitional care. We've done a survey. It was less than 30% of those with celiac disease in late adolescence were getting any follow-up care. And the follow-up care depended on was most if a a pediatric gastroenterologist had referred to an adult gastroenterologist.
Dr. Green, thank you for an outstanding grand round.
Thanks very much.
So much for your rescue.
So I think what we do here is,